I'm Dr. Fakir Rabari, and this is community-acquired pneumonia in adults. Respiratory tract infections can be divided to upper respiratory tract infections and lower respiratory tract infections. Common cold, which is the most common upper respiratory tract infection, primarily affects the nasal cavity and the sinus area. Otitis, which is basically the infection of the ear, is also considered an upper respiratory tract infection. You can also have pharyngitis, which is the infection of the pharynx. Pharynx is, of course, the canal that connects the nose to the throat. And lastly, you can have rhinosinusitis, which is primarily the infection of the sinus cavity. We can also have lower respiratory tract infections. There is something called bronchitis. There is the left bronchus and the right bronchus that connect the trachea to the two lungs, and the inflammation of the bronchi will lead to bronchitis. And then there's influenza and pneumonia that can cause infection deeper into the lungs, leading to problems with oxygenation. And of course, you can have pulmonary tuberculosis, which we will discuss later. Now, let's take a look at pneumonia. Pneumonia is a form of acute respiratory tract infection that affects the lungs. When an individual has pneumonia, the alveoli in the lungs are filled with pus and fluid, which makes breathing painful and limits oxygen intake. In 1901, Sir William Osler noted in the 4th edition of his book, The Principles and Practice of Medicine, that the most widespread and fatal of all acute diseases, pneumonia, is now captain of the men of death. Over a century later, the prominence of pneumonia as a clinical entity remains. In fact, it remains among the top 10 most common causes of death, and it is the single most common cause of infection-related mortality. Now, let's take a look at the anatomy of the lungs. As you can see, there are two zones in the lungs. There is the conducting zone and there's the respiratory zone. The conducting zone basically consists of trachea, bronchi, and bronchioles. As you can see, as we go deeper into the lung, the number of branches increase. So when you get to the alveolar sacs, there is an extreme number of sacs, which is intended to increase the surface area in order to allow oxygenation of the blood. Now, when there's inflammation in the conducting zone, such as bronchitis, it becomes difficult because this area is inflamed, it becomes difficult for the air to go through, so it will be difficult and painful for the patient to breathe. Now, when we have a more severe infection such as pneumonia, there will be deeper into the respiratory zone. So now the patient will have respiratory issues. So there will be marked hypoxia in the patient. Now let's analyze the lung on a cellular level. Now I'd like to bring your attention to the structure of alveolar. So note that in the alveoli, there are type 1 epithelial cells and type 2 epithelial cells. And type 2 epithelial cells actually secrete surfactant, and surfactant has a crucial role in maintaining alveolar structure by reducing surface tension. And the reason it is important to know that these type 2 epithelial cells secrete surfactant is that surfactant can actually affect antibiotics. The most important antibiotic that's affected by surfactant is daptomycin. Daptomycin is completely deactivated by surfactant. So while daptomycin is an excellent antibiotic for treatment of MRSA infections, it should never be used for respiratory tract infections because by the time daptomycin gets to the alveoli, it will be deactivated by surfactant. So you should never ever use daptomycin for pneumonia. Now, vancomycin, linezolid, and ceftaroline are not affected by surfactant, and they are used for treatment of MRSA pneumonia. Now let's take a look at the pathophysiology of pneumonia. As I mentioned, there are two zones in the lower respiratory tract. There's the conducting zone and there's the respiratory zone, which is basically the lung parenchyma. Now the lung has a elaborate system of host defenses that when functioning properly, they actually are very effective in protecting against pathogen invasion of the lungs. Now, for the most part, infections in lower respiratory tract occurs in patients with impaired host defenses, usually due to genetic disorders or in compromised ciliary function such as patients who smoke. It is important to note that all individuals are at risk for development of pneumonia. Now, some individuals have higher risk of getting pneumonia. There are different ways of getting pneumonia. Inhalation is the most common route. Inhalation of infectious particle is the primary route that leads to development of pneumonia. Aspiration of oral flora can also lead to pneumonia, which we call aspiration pneumonia. Now, note that this typically includes the flora in the mouth and possibly what's in the gastric content, but it's unlikely to include anything from anything past the stomach. So it's unlikely to include anything from the intestine. So bacteroides are extremely unlikely. There are also other possibilities of getting pneumonia. For example, if someone has bloodstream infection, because the blood goes to the lung where oxygen exchange occurs, that infected blood can actually infect pneumonia. You can also get pneumonia from invasive procedures such as intubation. Now, while these are possibilities, they are not as common. So the most common route of getting pneumonia is by inhalation. Now, let's take a look at chest radiograph, also known as chest X-ray. Now, when we look at the film in a normal chest radiograph, it's supposed to be clear. So generally speaking, it's clear. The lungs are clear. You can you can see the heart, and you can see the diaphragm. Now, when there are things in the lung, what we see on the film is increased opacity, which we call infiltrate. Now, these infiltrates or increased opacities, which you will see in chest X-rays B and C, they could be due to different things. Some of the possibilities include water in the lung, which could be, so if you see water on the chest X-ray as infiltrate, it would be common in patients with heart failure who have fluid retention, patients with low albumin, for example. Cirrhotic patients also have fluid retention, so you will see these fluids as infiltrate on chest X-ray. The content can also be pus, which will be the case in pneumonia. So if the patient has pneumonia and there's pus in the lungs, you will see infiltrate on the chest X-ray. There could also be blood, which is the case in trauma. So if somebody has ruptured their lungs, there will be blood in the lungs, which will show as infiltrate. And of course, the infiltrates could be cells, which will be the case in cancer. So if there are cancer cells in the lungs, they will show as infiltrates. Now, there are different ways of describing infiltrates. Two of the common ones that you will encounter are patchy infiltrates and dense consolidation. So when, patchy infiltrate could be usually due to either presence of fluids or viral infections or atypical organisms. And when you have dense consolidation, as you can see in film C, dense consolidation is usually more likely to be due to non-atypical organisms such as gram-positive and gram-negative organisms. Now, keep in mind that the chest radiograph is just a tool to help with diagnosis. There's no way to know for sure what's causing the infiltrates. It's important to use chest X-ray with clinical judgment. Another thing that can show up as infiltrate is atelectasis, which is basically the collapse of areas of the lung. So that's also something that you will see frequently. Now, let's take a look at reliable resources for lower respiratory tract infection. Infectious Diseases Society of America and the American Thoracic Society developed most of the guidelines for lower respiratory tract infection. The first guideline is the 2005 ATS-IDSA guidelines for for the management of adults with hospital-acquired, ventilator-associated, and healthcare-associated pneumonia. This guideline is particularly useful if you need information about healthcare-associated pneumonia. There's also the 2007 IDSA ATS guidelines on the management of community-acquired pneumonia in adults. Now, there was a 2009 IDSA guidelines for seasonal influenza in adults and children, but this guideline is no longer used because it's outdated. Instead, we use the 2011 CDC guidelines for antiviral agents for the treatment and chemoprophylaxis of influenza. There's also the 2016 IDSA ATS guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. There is also the 2018 IDSA guidelines on seasonal influenza that was recently published. Now, in October of 2019, after 12 long years, IDSA and AST together developed updated guidelines for community-acquired pneumonia, which borrows some components from the 2007 guidelines. We will discuss those shortly. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia. Let's review what pharmacokinetics means. Traditionally, pharmacokinetics is known as what the body does to the drug. It basically involves ADME, absorption, distribution, metabolism, and elimination. It's important to consider absorption so we know the bioavailability of drugs. When it comes to distribution, it's important to know protein binding. So for example, some patients may have low albumin. Albumin is the #1 protein that binds antibiotics. When it comes to metabolism, it is important to know if specifically a drug is metabolized with the CYP enzyme. That could include drug interactions. And of course, when it comes to elimination, it's important to consider renal, biliary, and fecal clearance. Now, when we say clinical pharmacokinetics, we basically mean application of these pharmacokinetic principles to safe and effective therapeutic management of drugs in individual patients. And the goal is enhancing efficacy while decreasing toxicity. What about pharmacodynamics? Pharmacodynamics is actually what the drug does to the body. In the case of antimicrobials, the body refers to the pathogens. So we don't really want the drug to do anything to the human body. So once a drug is given to a patient, the body will handle the drug. So there will be absorption, distribution, and elimination. So this is the pharmacokinetic properties. And then there will be concentration in the body fluids and also at the site of infection. And then at the site of infection is when you want the drug to do something to the pathogens. And that will be the pharmacodynamic outcomes, which we refer to as PK/PD. And of course, there are things that antibiotics do to the body, and those are referred to as toxicodynamics. These are the things that we don't really want antibiotics to do to the body. Here are some important parameters to know. On the horizontal axis, we're looking at time, and on the vertical axis, we're looking at concentration of drug. So once a drug is given, at the end of infusion, you get the maximum concentration, and that's referred to as peak or Cmax. And then once we stop the infusion, the body starts to clear it. So the concentration goes down until it's time for the next dose. At that time, we have the minimum concentration or trough, also referred to as Cmin. And then the next dose is given and the drug goes up. And then at the end of infusion, the body starts to clear. There's also the concept of area under the curve, which is all the shaded area here, for a 24-hour period. So it doesn't matter how frequently you give the dose, the AUC is often from time 0 to 24 hours. So if this drug was given once a day, you would only have one of these over 24 hours. Also, if this drug was given every 8 hours, then you would have 3 of these peaks. But regardless, AUC is the area under the curve for a 24-hour period. And of course, you could get the level at any time between peak and trough, and that would be considered a random level. Now, when it comes to antibiotic, these things only tell you how the body is handling the drug. So whether it's AUC or the peak or the trough, it's basically telling you how much drug is left in the body at a specific time. It doesn't necessarily tell you anything about the pharmacodynamics of the drug, because it doesn't really tell you anything about the organism, and we need to know something about the organism. And what we need to know about the organism is the MIC, or the minimum inhibitory concentration. We can combine these pharmacokinetic parameters with MIC to get PK/PD indices. So the three commonly used are the peak to MIC ratio, the AUC to MIC ratio, or the time above MIC. So when the concentration goes above this MIC concentration, it will go above and then eventually it will go down and then go below the MIC. The time it takes to go above the MIC and then below the MIC, that's referred to as time above MIC. In this picture, on the horizontal axis, we're looking at time, and the units of time are hour. And on the vertical axis, we're looking at in the log drop in the CFU, or colony forming units of bacterial growth. So CFUs are basically units of measuring how much bacteria grow on culture. So in all three of these experiments, we have the control. So the red circles are control, meaning that if we don't use any antibiotics, we just let the organism grow. So as time goes on, bacteria grow in the absence of antibiotics. Now the question is, if we start to introduce antibiotics, how much does it prevent growth of bacteria? MIC is the minimum inhibitory concentration of a specific antibiotic for a specific organism. So in these experiments, we're giving antibiotics in increasing concentration and see how much increasing the concentration affect the growth. So for example, on the left hand side, we're looking at the antibiotic tobramycin. So if we give a quarter of the MIC, as time goes on, you can see that the growth of bacteria slows down but doesn't completely prohibit it. Now if we gave exactly at MIC concentration, as you can see that as the time goes on, bacteria start to die. So the colony forming units start to drop. Now at higher concentration, so for example at 4 MICs, you can see that bacterial growth actually drops faster, and as we increase the concentration, this drop in growth of bacteria becomes larger and larger. This suggests that tobramycin has concentration dependent killing, meaning that the more of a concentration of tobramycin that we use, the more the growth of this organism was dropped. Now let's look at ciprofloxacin. Ciprofloxacin, they did the same experiment. So you can see that as they increase the concentration of ciprofloxacin, more and more of the organism died as time went on. Now compare that to ticarcillin, which is a beta-lactam. Now as they increase the concentration of this beta-lactam, you can see that the organism dropped, but at some point, increasing the concentration didn't make a difference anymore. So for example, once we reach a concentration 4 times the MIC, we got the maximum amount of killing. So 16 times the MIC in negligible amounts. In fact, a concentration 24 times the MIC made no difference compared to 16 times MIC. And this suggests that beta-lactams do not have concentration dependent killing, whereas tobramycin, which is an aminoglycoside, and ciprofloxacin, which is a fluoroquinolone, these two show concentration dependent killing because at the highest concentration of these antibiotics resulted in the most amount of killing. So generally speaking, antibiotics can be divided into concentration dependent and concentration independent killing. Now we're looking at the evolution of PK/PD. So as time went on, then clinicians started to refer to concentration dependent as time dependent. So we had concentration dependent and then we had time dependent. And as I showed you the examples of fluoroquinolones and aminoglycosides, those are concentration dependent. And then the time dependent would be the beta-lactams as well as vancomycin. And the PK/PD parameter for time dependent, specifically for beta-lactam, is the time above MIC. So it's not necessarily the concentration of beta-lactams, it's more of how long the concentration is above the MIC that would result in maximum killing of organisms. Now compare that to concentration dependent. So if you have a high concentration, the ratio of peak concentration to MIC, the higher this concentration will result to the maximum amount of killing. And then there's the concept of AUC, or area under the curve, to MIC ratio, which is used for aminoglycosides and fluoroquinolones, which I will explain more. But this AUC to MIC is also used for vancomycin. So generally speaking, peak to MIC ratio is used for concentration dependent, and time above MIC is used for time dependent. And then AUC to MIC, it just depends. For some antibiotics, AUC to MIC means concentration dependent, and for some antibiotics such as vancomycin, it just means time dependent. Now here you can see that the PK/PD target for beta-lactams is time above MIC. For carbapenem specifically, you need time above MIC for at least 40% of the dosing interval to get bactericidal activity, whereas for cephalosporins, at least 60% of the dosing interval is required. For penicillins, is 50% time above MIC. Now, it is also alternatively proposed that time above MIC is best to be increased to 100% of the time, especially in critically ill patients, in order to maximize the efficacy of these beta-lactams. For fluoroquinolones, you can see that the PK/PD target is AUC to MIC. For majority of the data is with gram negative, so it's proposed an AUC to MIC ratio of more than 125 to 250 is required for gram negative activity. For gram positive, a lower target of at least 30 is proposed. In this picture, we're looking at the bacterial 70S ribosome, which consists of the 50S subunit and the 30S subunit. The 50S subunit and the 30S subunit will come together around the mRNA or messenger RNA in the bacteria, and tRNAs will actually carry an amino acid and bring it to the ribosome in order to start the translation process. Generally speaking, translation consists of initiation, elongation, and termination steps. Some of the antibiotics that are important to know are clindamycin, linezolid, and macrolides, which all of which bind in the 50S ribosome, and they block the peptide bond formation between the different amino acids. As a result, protein synthesis will be inhibited. Other antibiotics that are important are also tetracyclines and aminoglycosides will bind to the 30S subunit and will also inhibit protein synthesis. So as you can see, aminoglycosides and tetracyclines will basically compete for the same site, which is the 30S, whereas clindamycin, linezolid, and macrolides basically compete for the same site in the 50S subunit. I have summarized some of the key pharmacokinetic, pharmacodynamic properties of these antibiotics in this table that you should review. Pay close attention to the adverse effects of these antibiotics. Aminoglycosides, for example, can cause nephrotoxicity, which is typically reversible. They can also cause ototoxicity, which is usually irreversible. And they can also rarely cause neuromuscular blockade. Keep in mind that aminoglycosides are not orally available, whereas the rest of these antibiotics listed in this table are orally available. These oral agents can cause gastrointestinal upset. They are also available as IV formulation. One thing that's important to know about tetracyclines is that they can cause photosensitivity, so that's an important counseling point for the patients. So they should avoid, exposure to the sun or tanning beds. It can also lead to deposition in bone and teeth, which is important in growing children. The major adverse effect of clindamycin is diarrhea, and clindamycin is actually associated with Clostridioides difficile infections. Macrolides are associated with QTc prolongation, so it's important to check EKG before starting someone on a macrolide. And linezolid has an adverse effect profile that's exposure dependent. So the more a patient is exposed to linezolid, the more adverse effects will occur. Now, generally speaking, linezolid leads to GI upset, headache, and occasionally it can cause serotonin syndrome, especially if it's used in combination with SSRIs. And within the first 2 weeks, you can also experience lactic acidosis. Now, beyond 2 weeks, patients may also experience bone marrow suppression. So this could be a drop in, white blood cells, so neutropenia. It can lead to drop in red blood cells, so anemia can happen beyond 2 weeks. Now, beyond 4 weeks, that's when neuropathy can happen, and rarely optic neuritis. Now, fluoroquinolones have a unique mechanism of action. They actually bind to topoisomerase 2 and 4. Therefore, they inhibit DNA synthesis in bacteria. Fluoroquinolones can cause neurotoxicity and tendonitis, which actually happens to be a black box warning. Vancomycin binds to diallo or D-alanine, which inhibits peptidoglycan synthesis. Peptidoglycan is a component of the cell wall in bacteria. Common adverse effects of vancomycin is Redman syndrome, which is actually, we can actually avoid that by prolonging the infusion time of vancomycin. And of course, vancomycin is nephrotoxic. Beta-lactams, such as penicillins, cephalosporins, carbapenems, and aztreonam, are available, most of them as IV, but many penicillins and cephalosporins are also available as PO. Carbapenems and aztreonam are strictly available as IV with no PO formulation available. Generally speaking, beta-lactams cause GI upset, hypersensitivity. So a penicillin allergy is the most common drug allergy that you will see in patients. They can cause skin reactions such as rash. In high doses, beta-lactams can cause seizures. And also occasionally beta-lactams can cause drug fever. So while we usually think of infections when a patient has fever, occasionally a beta-lactam itself can cause a fever, which we refer to as drug fever. And we also can have beta-lactams in combination with beta-lactamase inhibitors. Now let's take a look at pharmacodynamics of beta-lactams. Let's use cefepime as an example. So let's say you're infusing cefepime 1 gram every 12 hours. So you give this twice a day. And what happens is that because every time we give a dose, the amount of time that this concentration goes above MIC is about 4 hours. So overall, over a 24-hour period, you have 4 hours here and 4 hours here. So overall, you have 8 hours out of 24. So the time above MIC for 1 gram Q 12 hours of cefepime is about 33%. Now, what happens if we double the dose? Instead of 1 gram Q12, we do 2 gram Q 12 hours. And you can see that you get a much larger peak. However, that doesn't necessarily translate to double the time above MIC. So what happens is that instead of 4 hours above MIC, you get 6 hours time above MIC for each dose. So overall, it's about 12 hours out of 24, which translates into 50% time above MIC. So by doubling the dose, we increase time above MIC. Now, what if instead of increasing the dose, we increase the frequency? So every 12 hours, we actually infuse this every 8 hours. So what happens is that you actually get 3 peaks. And because you now have 3 of those 4 hours, so you get 12 hours out of 24. So that's 50% time above MIC. So essentially, by giving 1 gram every 8 hours, we achieve the same 50% time above MIC as doubling the dose. So from a pharmacodynamic standpoint, it's equivalent. The advantage of increasing the frequency instead of doubling the dose or increasing the dose is that overall throughout the day you give less of the drug. So 2 gram Q12 will end up with 4 grams over a 24-hour period. With 1 gram every 8 hours, you end up with 3 grams every 24 hours. So that has, from a toxicodynamic perspective, is less likely to cause toxicity because we give less of the drug. Yet from a pharmacodynamic perspective, we achieve the same time above MIC. Now, another thing that we can do is to extend the infusion time. So normally cefepime is dosed over a 30-minute period, which gives you that 4-hour time above MIC for each dose. And if we were to infuse this instead over a 3-hour period, so it actually increases the time above MIC without increasing the dose or the frequency. And ultimately, we can do continuous infusion. So basically, the entire daily dose can be infused over 24 hours. And what happens is that once the concentration goes above MIC, because we never stop the infusion, it continues to stay above MIC, and that's how we get time above MIC of 100% of the dosing interval. We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia. Now, let's distinguish between various types of pneumonia using patient-specific factors, clinical manifestations, and diagnostic testing. Here are some key definitions that you should know. So, by definition, pneumonia is a new lung infiltrate on the chest X-ray plus clinical evidence that the infiltrate is of an infectious origin. Now keep in mind that while this is the standard definition of pneumonia, for many patients, pneumonia is a clinical diagnosis. Now, generally speaking, there are two types of pneumonia patients. There are community dwelling patients, which means that there are patients who are not hospitalized, so they are residing in the community, and that consists of community-acquired pneumonia and healthcare-associated pneumonia. So these two types of pneumonia patients actually reside in the community. Whereas we have nosocomial pneumonia, and patients with nosocomial pneumonia will be residing in the hospital. So the two types of nosocomial pneumonia are hospital-acquired pneumonia and ventilator-associated pneumonia. Now, by definition, community-acquired pneumonia is pneumonia that occurs outside of the hospital. Even if a patient gets hospitalized and if the pneumonia develops within the first 48 hours of hospitalization, it is considered community-acquired pneumonia. And that's because there's an incubation time. For bacteria to grow and cause actual infection, it typically takes some time. So if pneumonia develops within the first 48 hours of hospitalization, that means these bacteria have already been growing. So the origin of these bacteria are from the community, not from the hospital. Whereas when you look at hospital-acquired pneumonia, it occurs beyond the 48 hours. So if the pneumonia occurs after 48 hours of hospitalization, it means that the origin of the bacteria is from the hospital. It's unlikely to be from the community. Now, there's also ventilator-associated pneumonia, which is basically beyond 48 to 72 hours, so at least 48 to 72 hours after intubation. So, if it's, pneumonia 4 days after intubation, it's considered ventilator-associated pneumonia. Now, keep in mind that all ventilator-associated pneumonia patients are actually hospitalized. So, VAP is a subset of HAP. But when you, diagnose a patient with pneumonia due to ventilator, we are not going to call it HAP. We actually call it VAP, even though those patients technically meet the definition of hospital-acquired pneumonia. So these are the three types of pneumonia that we will focus on. There's also healthcare-associated pneumonia that was part of the 2005 guidelines. However, the 2016 guideline removed HCAP from the guideline, and I will explain more on why that is. There's also aspiration pneumonia. Anytime a patient aspirates oral flora and those flora make it to the lungs, it can actually cause aspiration pneumonia. And these are typically due to anaerobic organisms. And by anaerobic, we're talking about Prevotella or Peptostreptococcus and things like that. We are not referring to Bacteroides or Clostridia species. Another thing that can happen due to aspiration, it could be a sterile aspiration. So it could be just gastric content without flora. And it can still cause some inflammation and reaction in the lungs. And we definitely call this aspiration pneumonitis rather than pneumonia. And some people call it chemical pneumonitis to make it clear that it is not due to organism. So aspiration pneumonitis or chemical pneumonitis should not be treated with antibiotics. Now, these are the criteria from the 2005 ATS-IDSA guidelines for diagnosis of HCAP. So you can see that, if the patient meets one of these 6 criteria, they will be considered HCAP. And the reason this was significant is that, if the patient has healthcare-associated pneumonia, they are more likely to have organisms that are multidrug-resistant. Now, the issue with this is that it's controversial because at least one study shows that specificity of these criteria was about 48%, 48 to 49%, and 1 out of 3 patients were misclassified as having multi-drug-resistant pathogen. So really, it leads to over-treatment of patients, and that's not good because over-treatment can also have, like toxicities and selection for more resistant organisms. So the 2016 IDSA guidelines for HAP and VAP actually removed the term HCAP. The 2019 IDSA guidelines for CAP actually did not include HCAP, and they said that they actually recommend abandoning the use of HCAP in order to select patients who need extended antibiotic coverage. Instead, they recommended that clinicians only cover empirically for MRSA and Pseudomonas in adults with CAP only if there are locally validated risk factors for either pathogen. Now, pneumonia in general is characterized by a newly recognized lung infiltrate on chest radiograph together with clinical symptoms. So the common symptoms will be fever, cough, sputum production, shortness of breath, and leukocytosis. Now, some patients can also have confusion and pleuritic chest pain. Now, there are some challenges in diagnosing pneumonia. For example, some patients, especially elderly patients, may not cough or produce sputum, or they may not have elevated white blood cell count. And some patients may not have a fever. Another issue is that it's hard to interpret the chest x-ray, especially in patients with chronic lung disease like COPD, patients who are obese, and patients who get the portable chest x-ray. So portable chest x-ray is the x-ray that's done at the bedside, usually because the patient is not able to move. So if the patient cannot go to the lab to get the x-ray, they will bring a portable x-ray to the patient room. And of course, even when you do have high quality chest x-ray, that infiltrate could be due to different causes. So for example, it could be just aspiration pneumonitis, it could be atelectasis, it could be fluids from either heart failure or cirrhosis, or it could be pulmonary infarction. We described the PK/PD properties of antibiotics used for pneumonia and distinguish between various types of pneumonia using patient-specific factors, clinical manifestations, and diagnostic testing. Now, let's use risk stratification tools to assess a patient's risk with pneumonia and aid in determining setting of treatment. Now, at this point, you should know that there are 4 different types of pneumonia. There's community-acquired pneumonia, there's healthcare-associated pneumonia, there's hospital-acquired pneumonia, and there's ventilator-associated pneumonia. Now, keep in mind that the severity of illness is different in different types of pneumonia. So here on the y-axis, you can see the mortality rate. So in community-acquired pneumonia, the mortality rate in this study was about 10%, which was significantly lower than a mortality rate in nosocomial pneumonia. Now, on the other end of the spectrum, we have ventilator-associated pneumonia, which has the highest rate of mortality compared to other types of pneumonia. So I would rank different types of pneumonia like this. Ventilator-associated pneumonia is the more severe disease, and community-acquired pneumonia is a less severe disease relative to other types of pneumonia. So if community-acquired pneumonia is a less severe disease, where exactly should patients with CAP be treated? Now, of course, the decision to hospitalize the patient ultimately depends on the clinician's judgment. So clinical judgment is important, but there are also some tools that can be used in order to aid in making that decision. So there's the Pneumonia Severity Index, or PSI. It's also referred to as the PORT score. And there's the Curve 65 score. Now, these scores are just to help. They are not to replace clinical judgment. The Curve 65 has not been as well validated as the PSI score, but because Curve 65 is more simple, it's more practical to use at bedside. So when a patient with CAP is presented, the severity of illness is assessed, and then the patients can, generally speaking, be in 3 different groups. So there could be the low risk group, moderate risk group, and high risk group. Now, low risk group patients typically can be treated as outpatient. unless they have an contraindication to outpatient, in which case they will be admitted to the hospital. For example, if a patient cannot take oral medications, then they need to be admitted to the hospital in order to receive intravenous antibiotics. And when we say outpatient treatment of patients, it basically means the patient will receive a prescription for antibiotics and they get discharged and they go home. Or if the patient is at the primary care physician's office, they receive a prescription and then they go home. Now, in moderate risk and high risk patients, these patients typically need to be admitted to the hospital, and in some severe cases, the patients need to be admitted to the ICU because of the hypoxia. Now, it doesn't mean that all high risk patients will be admitted to the ICU. This will basically depends, on the case by case basis. Now, the 2019 IDSA guideline for CAP actually prefers the PSI over the Curve 65 score to determine the need for hospitalization in adults diagnosed with CAP. So here's what Curve 65 is. So the C stands for confusion. So if the patient has altered mental status, they get 1 point. The U is for uremia or BUN of 20 or higher, which will give you 1 point. The R is for respiratory rate of 30 or higher, which will give you 1 point. The B is for blood pressure of 90/60 or less. And of course, the 65 is for age 65 or higher. So once you calculate the patient's Curve 65 score, if they get a score of 0 or 1, the risk of mortality is about 1.5%. So because the mortality risk is low, the patients may be treated as outpatient. Of course, not to replace clinical judgment, but generally speaking. And a score of 2 or higher, basically mortality rate approaches 10% or higher, and that's exactly why the patients typically are admitted to the hospital in order to closely monitor them to make sure that they do not clinically deteriorate. And here's how the PSI score looks like. As you can see, it's very complicated. So you do not need to memorize this. There are online calculators that you can use if you wanted to use the PSI score. Now, the 2019 IDSA guideline for CAP uses the same criteria as the 2007 guideline for classifying patients as severe community-acquired pneumonia. So there are 2 major criteria and there are several minor criteria. So if the patient has one of the 2 major criteria, it will be considered severe pneumonia. And basically severe pneumonia, for the most part, the patients will likely need to be in the ICU. So as you can see, the criteria here is septic shock with need for vasopressor. So this can only happen in the ICU. And of course, respiratory failure requiring mechanical ventilation. So both vasopressor and mechanical ventilation will require patients to be admitted to the ICU. Now, if someone has 3 or more minor criteria, they will also be classified as severe pneumonia. However, depending on the minor criteria, the patient may not necessarily need to be admitted to the ICU. But the reason I am mentioning these criteria for determining what's severe CAP and what's non-severe CAP is that the treatment actually depends on it. So the treatment for severe CAP might slightly be different than the treatment for non-severe CAP. So if someone does not meet these criteria, they will be considered non-severe. We describe the PK/PD properties of antibiotics used for pneumonia and distinguish between various types of pneumonia, and use the risk stratification tools to assess a patient's risk with pneumonia and aid in determining setting of treatment. Now let's list the likely causative pathogens for each type of pneumonia, including susceptibility profiles and patient risk factors for multidrug-resistant pathogens. Now at this point, you should know that VAP is a more severe type of pneumonia and is associated with more resistant pathogens, and CAP, or community-acquired pneumonia, is a less severe pneumonia and less resistant pathogens cause it. Now let's take a look at the common causes of community-acquired pneumonia. Viruses by far are the most common causes of CAP. However, when it comes to bacterial causes of community-acquired pneumonia, Streptococcus pneumoniae is by far the #1 respiratory pathogen causing pneumonia. Now, although Staphylococcus aureus can also cause CAP, not every patient needs MRSA coverage, and we'll talk about that more shortly. Now, there are a couple of gram-negative organisms that are likely to cause CAP, so Haemophilus influenzae and Moraxella catarrhalis. Of note, these two pathogens in the United States are likely to produce beta-lactamases. So that's important to keep in mind when we select treatment. And lastly, there are atypical organisms that can cause community-acquired pneumonia, such as Legionella, Chlamydia pneumoniae, and Mycoplasma pneumoniae. Now, when it comes to nosocomial pneumonia, you're more likely to have multi-drug-resistant organisms causing HAP and VAP. Of course, Staphylococcus aureus is one of the #1 organisms causing nosocomial pneumonia, and in this case, often the strains are MRSA. And of course, just like CAP, Streptococcus pneumoniae is the #1 respiratory organism that can also cause pneumonia in the nosocomial setting. And when it comes to gram-negative, we have some of these multi-drug-resistant gram-negative rods. So Pseudomonas aeruginosa, as well as Klebsiella pneumoniae and Acinetobacter species, which often tend to be resistant to multiple drugs. Now let's take a look at the CDC EPIC study that was published in 2015, and it was a population-based surveillance study for community-acquired pneumonia requiring hospitalization among patients adults 18 years of age or older in 5 hospitals in Chicago and Nashville. Now, this study looked at 2,320 patients, and what they were trying to do is to identify common causes of community-acquired pneumonia requiring hospitalization. Now, as you can see, in general, no cause is found in more than half of the patients who are hospitalized for CAP in the United States. The second thing that you will find here is that viruses are actually more common than bacteria. So you can see here human rhinoviruses, influenza, coronaviruses. And while Legionella and Enterobacterialis are found among hospitalized patients, really they are rarely found in outpatient community-acquired pneumonia. And what I mean by that is community-acquired pneumonia that's not severe, that can be treated outpatient. And we'll talk more about that shortly. The CDC has designated a serious threat level to drug-resistant Streptococcus pneumoniae. The mechanism of resistance of Streptococcus pneumoniae to beta-lactams involves alterations in the penicillin binding proteins or transpeptidase, which are the binding sites for beta-lactams. Now, note that it does not involve production of beta-lactamases. So beta-lactamase inhibitors are not going to overcome this resistance. So in particular, penicillins bind penicillin binding protein 1A, 1B, 2A, 2B, and 2X, as well as 3. Strep pneumo can also acquire ERMB gene, which alters the binding site for macrolides, as well as it can acquire the MEF-A gene, which encodes an efflux pump for macrolides. Now, let's take a look at the rate of resistance in Streptococcus pneumonia. The overall rate of macrolide resistance is almost 40%, and the rate is actually higher in the ambulatory care compared to the inpatient setting. The rate is also significantly higher in respiratory isolates compared to blood isolates. And in some regions, the rates were less than 25%, but even in those regions, the rate in respiratory isolates specifically were still higher than 25%. In California, the rate is higher in Southern California compared to Northern California. Tetracycline resistant is also high, 12 to 19% of the isolates. Penicillin resistant is also high at 35%, and amoxicillin resistant is 4 to 5%. Ceftriaxone resistant is relatively low, and levofloxacin resistant is very low. Now, the other organisms, Haemophilus influenzae, as well as Moraxella catarrhalis, they produce beta-lactamases. In fact, more than 90% of Moraxella make beta-lactamases, and up to 30% of H. flu produce beta-lactamases. Now here is information from two different guidelines. The first guideline is the HAP and VAP guideline. So here they have identified risk factors for MRSA in HAP and VAP, as well as risk factors for multi-drug resistant Pseudomonas in HAP and VAP. So the common risk factor for these two is that if a patient has received IV antibiotics in the previous 90 days, that is a risk factor for selection for MRSA, as well as selection for multi-drug resistant Pseudomonas. If someone has these risk factors, they should be covered for MRSA and for multi-drug resistant Pseudomonas. Now for multi-drug resistant Pseudomonas, also two other risk factors include mechanical ventilation as well as history of chronic obstructive pulmonary disease. Now, when we look at the guidelines for CAP, you can see that for MRSA or Pseudomonas, they actually recommend to use a locally validated risk factor for either pathogen. So it really depends on the hospital because they couldn't find a validated risk factor that will work across the country. And one strong risk factor for MRSA or Pseudomonas is actually a prior history of isolation of these organisms, especially if it's in the respiratory tract. So if somebody had a sputum culture in the past that actually grows Pseudomonas or MRSA, then the next time that patient has CAP, they're more likely to have Pseudomonas or MRSA. Even if it's not a sputum culture. So let's say if someone had a urine culture or a blood culture that had MRSA or Pseudomonas, when they get CAP, they're more likely to have MRSA or Pseudomonas. And of course, because Streptococcus pneumonia is the #1 cause of community-acquired pneumonia, there are also risk factors for drug-resistant strep pneumo. So comorbidities, specifically chronic heart disease, such as heart failure, chronic lung disease like COPD, chronic liver disease like cirrhosis, and chronic renal disease like CKD, these are likely to select for drug-resistant strep pneumo. So you can see that these patients, including patients with diabetes, alcoholism, malignancy, and asplenia, they're more likely to be exposed to healthcare settings. So they're more likely to be resistant, to have at risk of having drug-resistant strep pneumo. Here I have listed the common antibiotics used for treatment of pneumonia. Now with Streptococcus pneumonia, I have broken it into two columns. So one is a wild type strep pneumo, and what I mean by that is that this is Streptococcus pneumoniae that you are likely to find in a healthy individual without risk factors for drug-resistant strep pneumo. And then there's a column for drug-resistant strep pneumo, and this is the isolate that you are more likely to isolate in someone with those comorbidities. For Staphylococcus aureus, of course, we need to distinguish between MSSA and MRSA, so it's important to know which one we need to cover because you can see many beta-lactams cover MSSA but not MRSA. And then for gram-negatives, H-flu and Moraxella catarrhalis are two common ones, so it's important to see which ones cover these. And then we have Pseudomonas as well as atypical cover, so you can see which antibiotics cover atypicals, in particular fluoroquinolones as well as tetracyclines and macrolides have excellent activity against atypical bacteria. We described the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia and distinguished between various types of pneumonia and used risk stratification tools and listed the likely causative pathogens for each type of pneumonia. Now, given a patient with community-acquired pneumonia, let's design appropriate empiric therapy. Here are the recommendations from the 2019 ADSA guidelines for CAP. When it comes to treatment of CAP, you need to consider those patients who need to be treated as outpatient and those who need to be treated as inpatient. Let's talk about outpatient empiric treatment of CAP first. Now, for outpatient management of CAP, we are limited to oral therapy. So we are limited to antibiotics that are actually available as oral therapy. The first thing we consider is that we actually break patients into two groups. One group would be the healthy patients without comorbidities, and these patients are less likely to have drug-resistant Streptococcus pneumoniae. The second group would be those with comorbidities, and those comorbidities we went over previously basically include chronic heart, lung, liver, or renal disease, as well as diabetes, alcoholism, malignancy, or asplenia. Now, for healthy patients without those comorbidities, combination therapy is unnecessary, so we can actually give them monotherapy with a single oral antibiotic. And the drug of choice for single agent therapy of outpatient therapy for CAP is amoxicillin 1 gram PO TID. And remember, this is outpatient, so for these patients we are unlikely to have a sputum culture. So because we're not going to have susceptibility results, we actually give a high dose amoxicillin in order to overcome resistance in strep pneumo in case this happens to be having a high MIC. Now, alternatively, if someone cannot tolerate amoxicillin because of contraindications or because of penicillin allergy, alternatively, we can use doxycycline or a macrolide. And the two macrolide options are azithromycin and clarithromycin. Now, the reason doxycycline is considered alternative is basically because of limited clinical trials with doxycycline. So there are more clinical studies with amoxicillin. So the efficacy of amoxicillin is proven and it's relatively safe. Now with macrolide, it's considered alternative because we are seeing an increased rate of pneumococcal resistant. Now if you know that in your local area the rate of resistance is less than 25%, you can actually use azithromycin monotherapy. Now, in our area at Loma Linda University Medical Center, the rate of macrolide resistant in Streptococcus pneumonia is actually more than 30%. Now, for those patients who have comorbidities, because they are at increased risk of having drug-resistant strep pneumo, you don't want to use a single agent, so we use a combination agent so that we have good coverage. So we have oral beta-lactam and we have macrolides as first line. And then if someone cannot tolerate that option, then alternatively, you can use a combination of oral beta-lactam with doxycycline. And of course, your options for oral beta-lactam could be a low-dose amoxicillin clavulanate. So, since you have another agent to cover it, a low dose will be okay. And of course, you can still have the option to use a high dose. With amoxicillin, we actually use the clavulanic acid combination in order to overcome the beta-lactamases from H. flu and Moraxella catarrhalis, because with this patient, you're more likely to have those strains. And of course, you can also use cephalosporins like cefodoxime and cefuroxime. And if you choose any of these, it has to be in combination with either azithromycin or doxycycline. Now, with these patients with comorbidities, we can also have a single monotherapy, so respiratory fluoroquinolones. Respiratory fluoroquinolones basically refers to fluoroquinolones that are active against Streptococcus pneumoniae. Because Streptococcus pneumoniae is the #1 respiratory pathogen, the fluoroquinolones that have activity against it are referred to as respiratory fluoroquinolone. In other words, ciprofloxacin doesn't have activity against strep pneumo, so therefore ciprofloxacin is not a respiratory fluoroquinolone. Now, this is considered first line in the guideline, and it helps with efficacy and with compliance. However, keep in mind that respiratory fluoroquinolones have a high risk of collateral damage, and there are many adverse effects listed as black box warning. So ideally, a better option would be oral beta-lactam plus a macrolide as opposed to a single respiratory fluoroquinolone because of collateral damage and the adverse effects. Now, when it comes to inpatient management of CAP, we basically need to identify severe and non-severe pneumonia. So basically, earlier we looked at criteria for severe CAP and non-severe. So if somebody has either one of these major criteria, or if they have at least 3 of the minor criteria, they would actually have severe CAP, and if they don't, they will have non-severe CAP. And the significance of severe CAP is the increased risk of mortality. So because patients are more likely to die from CAP, if they have severe CAP, you want to make sure that you have an optimal regimen for those patients. Now let's take a look at non-severe patients, and we're specifically looking at patients who do not have any risk factors for either MRSA or Pseudomonas. So if these patients were sick enough to be admitted to the hospital, so this is an inpatient management, but not basically classified as non-severe, Because patients who get hospitalized, they're sick enough to and often cannot tolerate oral. These agents happen to be IV initially, although if they can tolerate oral, it's okay to give them oral medication. But you will see in hospital is that often the very first doses of these antibiotics are given as IV. It also helps with absorption, because if you give oral antibiotics, it takes some time for the antibiotic to be absorbed and be available at the site of infection. So the IV antibiotics also help with that, to get the antibiotic to the site of infection as fast as possible. So you will see that now we have IV beta-lactams as a possibility. And because of the mortality benefit in inpatient patients, we use a combination. So monotherapy with beta-lactam is no longer an option if someone is hospitalized. We want to basically combine it with either a macrolide or doxycycline. And the reason is that, probably the underlying cause is that beta-lactams don't have activity against atypical agents. So by combining the beta-lactam with either azithromycin or doxycycline, you also get that extra atypical coverage. And in clinical trials, or I should say in the literature, we have seen that this combination can actually reduce mortality. So here are the IV beta-lactams that are listed. Now you will see that ceftaroline is listed here, and you will realize that ceftaroline is actually a beta-lactam that's active against MRSA. However, the guidelines don't recommend using ceftaroline for MRSA coverage specifically because of the lack of clinical trials in MRSA pneumonia. So there hasn't been a proven efficacy of ceftaroline for MRSA pneumonia yet. So the only use of ceftaroline so far in the guideline is just like the same thing as ceftriaxone, is to cover Streptococcus pneumoniae and some of those common organisms that cause pneumonia, but not MRSA. And when it comes to macrolides, we have azithromycin. The only macrolide available as IV. Clarithromycin is only available as PO. Now, alternatively, we can also have monotherapy with the fluoroquinolone. So and it has to be a respiratory fluoroquinolone, either levofloxacin and moxifloxacin. So this is also considered first line. But again, keep in mind that this is associated with collateral damage and adverse effects. I should also mention that the beta-lactam plus macrolide is first line, but beta-lactam plus doxycycline is considered alternatives because there is less evidence with doxycycline. Now, when it comes to severe CAP, we actually do not use monotherapy with fluoroquinolones. So we, because of the increased risk of mortality, we want to make sure that we have a combination that is very likely to be active against the likely causative agent. So we use a combination of beta-lactam plus macrolide or beta-lactam plus a fluoroquinolone, and both of them are considered first line. And of course, the preference will be to beta-lactam plus macrolide because of the collateral damage of fluoroquinolone. Now, doxycycline is not listed for severe, again, because of the lack of evidence with doxycycline, and we don't really want to take a chance with severe because of the increased risk of mortality. For those patients who have risk factors for MRSA or Pseudomonas, here are the recommendations. So if someone actually had a history of MRSA isolation, so either from a past sputum culture or from a blood culture, if someone has a history of that, then the guidelines recommend that regardless of whether it's non-severe or severe, to add MRSA coverage. And the two options that we have are IV vancomycin or linezolid, either IV or PO. You do not want to use PO vancomycin because it's not absorbed, so it will not be useful. But IV vancomycin is an excellent option. Now, they also say that since you are adding MRSA coverage, it's also important to make sure that you obtain cultures, so sputum culture, as well as for MRSA nasal PCR, in order to either de-escalate therapy, meaning that if you don't grow MRSA, you will basically discontinue vancomycin or linezolid, or if you do actually grow MRSA on the culture, or if the nasal PCR tests positive for MRSA, then you know that you did the right thing and you will continue therapy. So that's the same thing for either severe or non-severe. Now, when it comes to history of Pseudomonas isolation, depending on what you selected for your treatment of pneumonia, all you have to do is to make sure that you use a Beta-lactam as part of your original regimen that covers Pseudomonas. So, for example, let's say here, if you had chosen ceftriaxone, if your patient has a history of Pseudomonas isolation, instead of ceftriaxone, you would use a Beta-lactam that has anti-Pseudomonal coverage. So either piptazo, cefepime, ceftazidime. And for patients who have penicillin allergy, where the reaction is anaphylaxis, we can use aztreonam, because aztreonam doesn't have the same side chain as the rest of the beta-lactams, with the exception of ceftazidime, as well as the core is very different. So the chemical structure of aztreonam looks very different, so it's less likely to have cross-reactivity. Now, with carbapenems, meropenem and imipenem, because they are very broad, you should only use them if the patient had a history of multidrug-resistant Pseudomonas, meaning that if in the past they had Pseudomonas that was resistant to piptazo or cefepime or ceftazidime, then you don't want to use those same agents. So you want to use something broader like meropenem. Now, it is important to obtain cultures to allow de-escalation or confirmation for continued therapy. In other words, if you do not grow Pseudomonas on the culture, then you can de-escalate these back to ceftriaxone. Or if you did grow Pseudomonas, then you know that you had made the right decision, and then you will continue these anti-Pseudomonal coverage. Now, the same is true for severe and non-severe, so the strategy is the same, it doesn't matter. If the patient has had hospitalization and IV antibiotics in the last 90 days, that's when the strategy is different between non-severe and severe. So for non-severe, you want to obtain culture and nasal PCR, but you do not want to start either you do not want to add MRSA coverage and you do not want to start using Pseudomonal coverage unless the culture results are positive. So you basically get the culture and you just wait for the results to come back. Now, if the results actually grow MRSA or Pseudomonas, then you can add coverage for those. And if they don't, then you know that you had done the right thing. Now, for severe, you don't want to do that because of the increased risk of mortality. So, if you get the culture and nasal PCR, but you actually go ahead and add the MRSA coverage and anti-Pseudomonal beta-lactam while you wait for the results. So you do not want to wait for the results to start these agents because of the increased risk of mortality. But for non-severe, you can actually take a watchful strategy. So, as long as the patient is stable and improving, you just wait for the culture results to come back. But you do, start antibodies for the usual pathogens. So you do start your ceftriaxone and azithromycin if you need to. Now, from an antimicrobial stewardship standpoint, it is important to de-escalate, for those patients that we added MRSA coverage and anti-Pseudomonal. In general, if after 48 hours, nothing has grown as far as MRSA and Pseudomonas, it is safe to de-escalate, meaning that you can discontinue MRSA coverage and you can change the anti-Pseudomonal agent to something narrower. Because that has been shown to be safe and it reduces duration of antibiotic treatment, length of hospitalization, and complications of broad spectrum therapy, specifically collateral damage. And lastly, the 2019 IDSA guidelines for the very first time had recommendations for aspiration pneumonia. And what they say is that they don't suggest routinely adding anaerobic coverage for suspected aspiration pneumonia unless the patient actually has a lung abscess or empyema. So lung abscess and empyema are more likely to actually grow anaerobic organisms. So outside of that, it's very unlikely that the patient will have anaerobic organisms growing. So it's not recommended to add metronidazole, for example. Now, for those who actually have lung abscess or empyema who need anaerobic coverage, if your the regimen that you're using actually covers anaerobic, it's fine. So if something like ampicillin sulbactam, alone is enough because it has anaerobic coverage. Now, if you're using something like cefepime or ceftriaxone, which does not have great anaerobic activity, then you can add clindamycin to it. A lot of studies actually have shown that clindamycin is superior to metronidazole. So if you have the option, you want to use clindamycin over metronidazole. But the key point is that for the most part, aspiration pneumonia does not need anaerobic coverage. We described the PK/PD properties of antibiotics used for pneumonia and distinguished between various types of pneumonia, and used risk stratification tools to assess a patient's risk with pneumonia and aid in determining setting for treatment, and listed likely causative pathogens for each type of pneumonia. We also designed appropriate empiric therapy for a patient with community-acquired pneumonia. Now let's recommend an appropriate duration of therapy for community-acquired pneumonia. Now, when it comes to duration of therapy for community-acquired pneumonia, it should be guided by a validated measure of clinical stability. And in general, criteria for clinical stability, which are actually from the 2007 IDSA guideline, is that you use things like vitals, so temperature, heart rate, respiratory rate, systolic blood pressure, oxygenation of the blood, as well as ability to maintain oral intake and normal mental status. So these are the criteria you can use to basically see if the patient is clinically stable. And then, depending on what's causing the pneumonia, so in general, pneumonia for the most part will be caused by common bacterial pathogens like Streptococcus pneumoniae. So you continue antibiotics until the patient achieves stability, but no less than 5 days. So if, let's say, after 3 days of antibiotics, the patient is clinically stable, you basically finish 5 days. But if you have finished 5 days and the patient has not achieved clinical stability, then you basically continue beyond 5 days until you achieve stability in the patient. Now, for MRSA and Pseudomonas specifically, the guidelines recommend a total of 7 days. So even if the patient has improved by day 5, it's important to finish 7 days of therapy. And then, if you have community-acquired pneumonia due to less common pathogens like Burkholderia, Mycobacterium, and fungi, then longer duration of therapy may be needed depending on what the organism is. So there are various guidelines out there for these less common pathogens, which are beyond the scope of this class. And then, if the community-acquired pneumonia is complicated by other infections, then you basically may need longer duration depending on what the infection is. So for example, if someone has meningitis may require longer duration of therapy. So even if you're done with the treatment for community-acquired pneumonia, you need to treat longer in order to finish treating meningitis. The same is true with endocarditis and deep-seated infections. In general, deep-seated infections require longer duration of therapy in order to eradicate those organisms. Now, as patients achieve clinical stability, it's important to switch from parenteral to oral antibiotics. And when we do that, you can either use the same agent. So for example, if you have something like azithromycin or fluoroquinolones, it's easy to have the same agent that was IV. Just use the oral bioequivalence of it. However, some agents are only available as IV. For example, ceftriaxone is only IV. In that case, you can find an oral equivalent of that agent as long as it's in the same class. So in general, a third generation cephalosporin, you can switch from an IV to an oral. The same is true with the penicillins and beta-lactams in general. Now, sometimes you may see that the patients may fail to achieve clinical stability within 5 days, and this in fact is associated with higher mortality rate. Now, this failure can be due to different things, so it's important to assess the cause of clinical failure. Sometimes this could be due to emergence of resistance while on treatment, and other times it could be complications or another infection that might be going on simultaneously. One tool that we can use is serial procalcitonin in order to see when it's safe to discontinue antibiotics if the patient needs a longer duration. So once it goes beyond 5 to 7 days, we can actually get serial procalcitonin, and if the levels become low, then that's an indication that treatment has been long enough and it would be safe to discontinue. This concludes this presentation.